Welcome to Strategies in Public Health, Using Law to Advance Health Equity. My name is Casey Deems, and I'll be running this Dialogue for Health web forum with my colleague, Jeff Bornstein. For today's agenda, we will have a welcome and introduction from Carmen R. Navarez. We'll then have a presentation from Matthew Penn and Samantha Bent-Weber, and then we will close out from Carmen. Next slide. So now it's time to meet the moderator of today's event, Dr. Carmen Rita Navarez. Dr. Navarez is the director of the PHI Center for Health Leadership and Impact, which runs the National Leadership Academy for the Public's Health, the director of Dialogue for Health, and the Senior Vice President Emeritus, External Relations and Preventive Medicine at the Public Health Institute. So welcome, Carmen.
Yeah, thank you so much, Casey. Good afternoon and good morning to everybody who's joined us so far. It's really exciting to be here with such excellent public health legal experts. We really hope that this will be a good opportunity for people in this audience to think about the points that come up in the presentations, but also to think about the comments that you have, think about the questions you may have, and feel free to pitch them in via the Q&A. We'll remind you several times during the presentation, but I'm going to try my best to reflect your questions back to the speakers so that they can have a chance to answer your questions, your most pressing thoughts. I want to introduce our first speaker, Matthew Penn, who is the director of the Public Health Law Program at the Centers for Disease Control and Prevention. At the center, he leads a team of analysts responsible for the agency's efforts in legal epidemiology and workforce development at the state, tribal, local, and territorial levels. So that's a lot of ground to cover, and he'll bring incredible expertise and perspective to this presentation today. And then our second presenter, next slide, is Samantha Bent-Weber. She is the team lead for research, innovation, and workforce capacity building at the Public Health Law Program at CDC, specializing in work to improve public health through the development of legal tools and the provision of legal technical assistance to state, tribal, local, and territorial governments, as well as public health officials at CDC. So this is really an exciting opportunity to hear from the two of them. They're going to talk through some of their tools. And again, I just want to remind people as we go through the presentations, feel free to use the Q&A to ask your questions. I'll be taking notes and I'll pitch those questions back to the speakers at the end of their presentations. But your questions and your comments are really, truly appreciated. So why don't we go on and proceed with the presentations. Matt?
Great, thanks so much. Take it away, Sam.
Hi, everyone. Thanks so much. Thank you, Carmen. Thank you to the Academy and the Center for Health Leadership and Practice. Welcome to all the attendees, and thanks for spending some time with us today. We're really happy to be able to connect with you, particularly given your wide range of experiences and areas of focus and representation across the country. Today, we're going to talk about using law to advance health equity. Next slide, please. We do have to offer a disclaimer. Please note that the materials here are for instructional and educational purposes only. They do not represent the official position of CDC, and they do not represent any agency determination or policy. And they are not meant to provide legal advice to you or your health department, or any other institutions you might represent. While Matthew and I are both licensed attorneys, we are, of course, not your attorney. And if you do need legal advice, please seek that advice from an attorney authorized to provide such legal representation. Next slide, please. So I just want to provide a quick overview of our session. We will cover several topical areas. First, we'll give you a quick overview of our objectives, why we've asked you to participate in this session. Then I will be presenting a case study that allows us to examine what structural inequities can look like in a community. And then Matthew will provide an overview of how the case study helps us to think about structural racism and other structural inequities. Then we will talk a little bit about how law can be used as a tool for advancing equity in the public health context. Next slide, please. So our objectives for this session are to explore a series of questions that will hopefully provide this audience with an opportunity to consider in a concrete way how sources of structural inequities, including racism, are manifested, relate to public health, and can be found in laws. We'd like to, so with that in mind, we'd like you to think about, as we examine the case study, how public health practitioners and others working in diverse settings might hear and think about this story. What sort of resonates with you? What do you take away from it? We'd like to ask you to think about how to identify equity challenges. Where do structural inequities appear in the context of public health work and public health practice, or work that is related to public health or adjacent to it? And then we'd like to begin to exploring ways to identify strategies for pursuing and achieving equity, to think about how public health practitioners can better incorporate law into their efforts to confront health inequities. Next slide, please. So our case study seeks to ask, how do public health practitioners, and for others in the audience, how do you all hear this story about a community's fundamental needs? Next slide, please. So I invite you to imagine a small city just outside Appalachia. It's called Zanesville, Ohio, and it's located in the southeastern part of Ohio, in the Appalachian foothills. This community, referred to by the name of the road on which most residents live, Coal Run, is very, very small. It's majority Black, and it's located a few miles outside of the city center. Next slide, please. The small city and its surrounding county are the site of a formerly robust but diminishing mining industry. The Coal Run community sits on top of long abandoned coal mines that left behind pollution that contaminated the groundwater. As a result, the residents cannot rely upon their wells for safe drinking water. As I mentioned, the community is outside of the city center, so it's semi-rural. The water corrodes and clogs and destroys everything that it touches. And as you can see from the picture, it looks something like this. Next slide, please. Because of this pollution in the water, the residents of Coal Run have had to rely on alternative methods to obtain safe water for basic needs like cooking, drinking, bathing. One of your neighbors reports that as a child, his parents would fill the family's bathtub and not change the water until 5 of the 10 children in the family had bathed, in order to preserve the water that they had to have trucked to their home and stored in their cistern. Another neighbor reports that he only does laundry when it rains. Indeed, to get by, residents of Coal Run have to do things like collect rainwater and melted snow from their rooftops, and they store that water in cisterns, but it frequently becomes infested with vermin. They reuse their dishwater after multiple meals, and many residents actually purchase water from a nearby water treatment plant, and they frequently spend up to 10 times more than those elsewhere in the area who do have access to running water and to public water. Many in the community have reported physical ailments and illnesses as a result of having poor water access. Next slide, please. So for almost 50 years, residents of this community lobbied public officials and other leaders to no avail. Indeed, between 1954 and 2002, residents of the community undertook efforts to obtain access to public water administered by the city of Zanesville or by the county. Until 2002, most residents still used outhouses. So I'd like to ask you to think about where you were and what your living conditions were like in 2002. Next slide, please. So as I mentioned, the community's members undertook a number of lobbying efforts over the course of 48 years, but their efforts fell on deaf ears. One county commissioner told the residents that you would not get water until President Bush dropped spiral bombs in the community and they hit good water. That same commissioner said that another community member's grandchildren, great-grandchildren, would be lucky to have running water. Another neighbor, out of desperation, contacted the public health department and was told to dig a well. Next slide, please. But as you can see from this map, the community's residents should not have to dig a well. This map shows us water lines within the county. You can see that Coal Run was surrounded by publicly administered water lines. So if you take a look at this map, and you'll see sort of in the center of the map, a kind of ovular blob that looks like a lake, that's where Coal Run is located. The triangle in the center of the map in this kind of green shaded area is the water treatment plant that I mentioned earlier. And so you can see the same water treatment plant actually provides much of the water to that runs through these blue water lines throughout the county. And as you can see, Coal Run is surrounded by these lines. Next slide, please. So something to note here, the water lines stop where the community begins. So if you take a closer look at this map, you see that the Coal Run neighborhood that we've been talking about down here at the bottom literally starts right here, and the water lines stop where the community begins. You'll see also that the majority of residents of Coal Run, as we've mentioned before, are non-white. You will also see that a substantial number of the residents along Adamsville Road and along the upper half of Langan Lane are white or unidentified by race. Now, anecdotally, the vast majority of residents of this area were white. In fact, the residents of Coal Run frequently stated that the water stopped where the Black people began. About 85% of Coal Run residents were Black, and it was one of the few and possibly the only majority Black community in the county. Notably, in 2002, the county was also 94% white and about 4% Black. Since then, the county's demographics haven't really changed much. So to sort of tell you what happens in this story, after trying to get public water for almost 50 years, Coal Run residents finally filed a complaint with the Ohio Civil Rights Commission in 2002, and they asserted a pattern and practice of discrimination that violated fair housing laws, federal fair housing laws. Something to note here is that the Fair Housing Act prohibits discrimination on the basis of race with respect to things like access to utilities. So not just housing, but also the things that are concomitant with housing, like utilities, like electricity, water, and so on. The Civil Rights Commission conducted an investigation and found evidence that the race of the Coal Run residents was a factor in the decision not to run water into the area. And so shortly after that determination, several public officials within the state of Ohio and within the county got together and said, well, we can find a way to resolve this issue. And we're able to identify the funds that were necessary in order to extend the water lines to the Coal Run neighborhood. And so in 2004, the process of building those water lines actually went underway. And shortly thereafter, community members, Coal Run residents, did get access to running water. So it took about 1.5 years to achieve what they had been trying to achieve for almost 50 years. After that, Coal Run residents filed a complaint with the Ohio Civil Rights Commission in 2002. And they assert, I'm sorry, not with the Ohio Civil Rights Commission. They filed a complaint in federal district court making similar allegations. And they asserted a pattern and practice of discrimination again in violation of several federal anti-discrimination laws. They won that case. They won that case in civil court. They survived summary judgment and received a $10 million judgment for damages, recognizing their many years of struggle and hardship, and at times illness as a result of not having access to publicly run water. With that, next slide, please. With that in mind, I'm going to pass this over to Matthew, who will help us to unpack the case study and to provide an overview of how public health and law can play a role in disentangling some of these forces that we've highlighted here today. Matthew?
Great. Thanks so much, Sam. So let's now unpack some takeaways from this case study. Next slide, please. So what does our case study tell us about the relationship among racism and other inequities, public health, and law? The story is really about a number of overlapping ideas. It's about racism and how the water line stopped where the Black community started. It's about intersectionality and how the inequities extended beyond the Black community of Coal Run and into other communities because of where they live. It's about law. And importantly, it's about expanding how we see public health practice and the work that we do. And ultimately, it's really about equity and justice and about using the power and the tools we have to make a difference. Next slide, please. In public health, as in much of our broader society, we have reached an important moment in our discussion about racism. We are moving beyond a conversation about racism as simply a collection of individual actions of morally flawed exceptions somehow operating outside the norms of society. This idea that, sure, racism happens, but then everything goes back to normal. Instead, we are moving towards a more comprehensive discussion about racism as a system of structures, practices, policies, and norms that create and sustain social, economic, and other conditions that shape well-being and life chances for specific populations. Next slide, please. Coal Run was one of the few, and possibly the only, majority Black community in this county. And let's be very clear about this. The Coal Run story is about racism. This is what racism looks like in our communities. The Coal Run story helps us to better understand how racism can be structural and systematic. It's not merely about individual hostility or grievance, although in this instance, it certainly appears that there was some of this, but rather about the ways that legal principles, policies, and practices work together to disadvantage some people on account of their phenotype. And another point to be clear about, in this instance, the community was not subjected to laws and policies that explicitly discriminated against them. Indeed, they were subjected to water laws that appeared on their surface to apply to all people in the community and apply in some equitable or equal fashion. But as we saw from the maps, the application and the implementation of those laws were in effect discriminatory. Next slide, please. When the Coal Run community filed their complaint, the county was approximately 96% white. At the same time, more than 32,000 other families in the county lacked access to running water. In 2000, when the Coal Run community began to ramp up their efforts to obtain water, median household income in the county was about $35,000 a year. While racism may have had a hand in shaping the Coal Run's community access to water, many other people elsewhere in the county, the overwhelming majority of whom were white, lacked access to running water, likely because of other factors such as socioeconomic status, rurality, geography, and maybe even civic voice. All of these factors are intersectional. They arise from and result in overlapping inequities. Next slide, please. These forms of disadvantage arise from the many conditions in which people live, which we refer to in public health as the social determinants of health. The public health dimensions of the Coal Run story draws our attention to the social determinants of health. These structural, economic, cultural, and political factors that order relationships, assign social status to members of different populations, distribute money, distribute power and other resources, and build or disrupt communities. In the case of Coal Run, the complicated infrastructure that allocates water resources across communities, the socioeconomic conditions of the community resulting from the loss of the coal mining industry, and the environmental degradation that resulted from years of coal mining. These conditions affected many more residents of the county beyond the residents of Coal Run. Next slide, please. But racism is often, next slide, please. There we go. But racism is often invisible or difficult to identify because it is embedded in law. Statutes, regulations, rules, policies, implementation practices, and judicial opinions are what drive our legal system and much of how our society operates. Historically, many of these legal norms were overtly and intentionally racist, targeting specific populations because of their race or ethnicity. But as we discussed earlier, legal norms can be neutral on their face, and most are now these days. And they need not be expressly racist to have a disproportionate impact on communities of color. Next slide, please. Law is a foundational determinant of health. Just as law is a system of rules, policies, and practices that can create disadvantage, it's also imperative to transforming those conditions of disadvantage. Law plays a central role in achieving two ends. It can profoundly shape the context in which people live to increase their access to the things they need, and to make it easier for them to make decisions about their health. And law has the power to redistribute resources, water lines, for instance, to make things that people need to live healthful lives more accessible. In this case, we saw how a legal intervention, filing a discrimination complaint with the Civil Rights Commission, was necessary for the health of the residents of Coal Run. But sometimes those kinds of legal interventions may not be the best approach because they take a long time, because they can be money intensive, or because a narrow adversarial proceeding is not in the best interest of the community. Next slide, please. But if this is the direction we're going, towards equity and justice, toward advancing and ultimately achieving health equity, particularly among people who have been disadvantaged because of racism, what does that mean? Health equity is when everyone has the opportunity to be as healthy as possible, to reach their full potential. And importantly, when we bring racism into discussion, it is when no one is disadvantaged from reaching this potential because of socially determined circumstances such as race. Health inequities are the result of African, Asian, Arab, Hispanic Americans, as well as American Indian and Alaska Native, and many others being denied the opportunity to achieve their full potential because of systemic racism. But as we've stated, racism is also entangled with other social forces. This is the intersectionality. Forces such as sexism, geographic isolation, economic and political marginalization, and others that sap the strength and good health and well-being of our entire society. Achieving health equity will require us to disentangle these forces and to employ a number of strategies to do so. Next slide, please. One such strategy may entail thinking about public health in an expansive way. in a way that situates public health as an important actor in other sectors that influence and shape individual and population health. As highlighted here by Leandris Laberde, the Associate Director of CDC's Office of Minority Health and Health Equity. She says, a focus on health equity may entail venturing beyond our boundaries in public health practice to matters intimately linked to health disparities such as housing, labor markets, or employment conditions, civic participation in forms of discrimination. Next slide, please. By extension, thinking expansively about public health practice can mean thinking expansively about the tools and the resources that can drive critical dimensions of public health practice. In this instance, law and policy and its related tools, methods, and interventions, really talking about the things that sit at the bottom of the health impact pyramid. Next slide, please. So incorporating law into public health practice to address health inequities. You know, we highlight the Coal Run story, not only because it helps us understand how structural racism operates and how it looks, how it presents, but also because it points to the relationship between public health and law, particularly for addressing health inequities. The Coal Run community faced a serious public health problem. They needed and struggled to obtain affordable access to clean and safe water. Think about how many times you have used water today. In this instance, they were able to get access to it by using legal strategies that exist outside of traditional public health practice. To summarize the high-level overview of the problem, racism and other forms of structural and systemic inequity are embedded in the law. Historically, they were built into the language of the laws, policies, and judicial opinions, but over time, they have become embedded in application, implementation, and enforcement of what may on the surface look like neutral laws and policies. But there remains an outstanding question. What is the role of public health to address these real equity challenges? From our perspective, an important starting point to answering this question is recognizing and implying this relationship between public health and the law. In our view, it's critical to advancing not only public health practice, but also equity, which, as we'll see a bit later, is at the center of the 10 essential public health services for public health practice. Next slide, please. So at CDC, we are working to develop frameworks and strategic approaches to addressing health inequities by recognizing the impact of structural racism and other structural and systemic factors on public health outcomes. And by extension, the work that we do in public health. Next slide, please. We are recognizing that while it is important to identify and document health disparities that undermine the health of Black, Latino, American Indian, Alaska Natives, Asian, Arab, and other populations, it is not enough to simply name the problem. Rather, we are emphasizing the significance of root causes by engaging in the collection and analysis of data that helps us better understand the social conditions or the social determinants that give rise to health disparities. We're recognizing the importance of providing context for why some populations experience poor health outcomes than others. Correspondingly, in developing these frameworks and strategies that move beyond simply documenting disparities, right? This idea that just data does it. We don't have to do anything but the science and collect the data. We're trying to centralize the importance of policy and health interventions that can facilitate change and ultimately improve health for more people. And in doing so, these strategies and frameworks recognize, as I emphasized earlier, the potential necessity of focusing our research and policy priorities on topic areas that may exist outside the, quote, traditional public health boundaries, looking at domains like discrimination or employment and labor market conditions, for instance. This means focusing on policy solutions that are rooted in science, as well as relying upon contextualized data and information. Next slide, please. So the good old 10 essential public health services. We have precedent for some of these approaches. In 2020, with the support of CDC, the de Beaumont Foundation, and the Public Health National Center for Innovations, updated the 10 essential public health services, which have been characterized as, quote, describing the public health activities that all communities should undertake. So let's note some important elements of this revised and updated framework. As a starting point, it places equity, and note that it's not health equity. It places equity at its center to both emphasize the fundamental importance of equity to public health practice, and from our perspective, to emphasize that in order to maximize the health of all people in all communities, we must center equity, not just in health, but in all those institutions, practices, and social conditions that impact all aspects of life. To achieve health equity, as we say here at CDC, to achieve health equity, the essential public health services actively promote policy systems and overall community conditions that enable optimal health for all and seek to remove systemic and structural barriers that have resulted in health inequities. Such barriers include poverty, racism, gender discrimination, ableism, and other forms of oppression. Everyone should have a fair and just opportunity to achieve optimal health and well-being. This is a statement from CDC about the 10 essential public health services. The 10 essential public health services provide a foundation for this direction. You'll note these barriers include what we have emphasized as the social determinants of health, right? It's talking about systems and structures and barriers, poverty, racism, gender discrimination. These are noted here also with the updated Healthy People 2030 framework. Next slide, please. These frameworks, like the 10 essential public health services, recognize the importance of law in improving the health and well-being of all people. In fact, when we sort of within CDC, we talk about paving the road to health equity. And over on that right-hand side, it says policy. I mean, it's one of there's 3 roads, and one of them policy. It's law, regulations, and rules to improve population health. So it's really central to this way forward as we work towards health equity and in equity in general. Next slide, please. And so from our perspective, the question becomes, what is the role of law in this story? I've noted that law has contributed substantially to inequities in health. Racism and other sources of inequity are embedded in our laws, policies, practices that execute and enforce laws, and in the systems that arise from them, all of which have undermined public health and well-being. At the same time, law has been central to improving public health. Indeed, many of us know about the important role that law has played in promoting public health by mandating seatbelt usage, establishing and maintaining federal clean air standards, clean water, regulating or banning toxic substances, and imposing food safety standards and labeling requirements, just to name a few. In this way, as we state here and has been documented elsewhere, law is a determinant of health. Laws can make us healthy, and laws can make us sick. With this awareness in mind, we ask, how can law help to achieve health equity? And how can public health practitioners draw upon law as a set of ideas, rules, policies, and practices to achieve health equity? Next slide, please. We propose that law fits into public health practice in a number of critical ways, some of which we don't explicitly identify here, that can help us to develop public health strategies for addressing health inequities. In addition to law being a determinant of health, law is something that can be studied, not just from the perspective of a lawyer advocate, but also from the perspective of a public health practitioner who wishes to trace and understand the relationship between law and health outcomes. Law is something that can be centralized in our efforts to disseminate research and build capacity among public health practitioners. I just want to highlight this quoted language in Allison Anderson's Lawyering in the Classroom. Quote, "A lawyer's primary task is translating human stories into legal stories. and retranslating legal story endings into solutions to human problems. Law is a storytelling profession. We think about these efforts in the context of legal advocacy, the law you're fighting for the client in a court setting. But these efforts can also be a part of a public health approach to discussing intractable injustices and inequities that impact health and are frequently connected to laws and policies. I think about the Cole Run story. We told a story about community, and we know this story because they pursued they pursued legal redress, and there was a record created through mechanisms of the law. And we know the story because they sought redress. And finally, law is something that can be a central part of efforts at collaboration, partnership, and policymaking, all in the effort to identify policy solutions. Next slide, please. Laws can be studied, which is an idea that kind of has two components. First, legal epidemiology is a set of methods that enable us to systemically study laws and policies to better understand what they say and what they do. Second, in doing so, we can begin to fill gaps in our understanding of health inequities by identifying root causes or the societal and systemic sources of inequities. Indeed, we want to note that much research on disparities tells us about gaps in health and well-being across race, gender, sex, socioeconomic status, and so on. But it frequently does not tell us why those gaps exist. What is the cause of those gaps? Studying laws and policies through legal epidemiology and other public health law research can help us to better examine why disparities in inequitable outcomes exist. The next slide, please. But of course, as many of us know and are familiar with, research is not enough. In better understanding what laws and policies say and do, we can also begin to translate and narrate our studies and analyses of laws and policies, to demystify it and to connect it to human stories. Both public health and law possess a narrative aspect that can be effective when they take complex concepts and frame them through the lens of real people in real communities. By engaging in storytelling, we can also begin to illuminate those root causes we mentioned earlier, to demonstrate how populations that experience disparities are real people trying to manage their lives and navigate complex institutions and environments. Next slide, please. And we wanted to note, and this is a bit of a tricky turn that we haven't totally resolved yet in this ongoing work, that we recognize that laws can be changed, but we shouldn't focus solely on the mechanics of changing laws. This process is also about restructuring power and restructuring our communities that lead to laws being changed. And it's also about recognizing that law is alive. It's constantly changing. This should not be foreign to health departments, but rather it's embedded. This idea is embedded in the 10 essential public health services, which the outputs being interventions that we haven't always paid a lot of attention to: laws and policies, ordinances, statutes, regulations. And that kind of intervention can have population impacts. And maybe we can even begin to rethink what it is we mean by the word intervention in public health. What are those interventions? Is it even an intervention? Or is it about building and expanding and restructuring power relationships and restructuring our communities to achieve better outcomes? Next slide, please. All of these factors come together in this pathway for public health law and equity. It is meant to be contextual and community-centered. It is also meant to help health departments and others think about their own frameworks and practices to bridge the 10 essential public health services focus on equity, law, and policy. It also seeks to outline some steps on how to build law into your equity-focused efforts. It includes 4 areas of emphasis: identifying local health equity challenges, which means recognizing that law is a determinant of health, studying law, what it says, what it does, and its impact on health outcomes. Deploying law's narrative and storytelling dimensions, and invoking law and engaging with law to pursue change. The pathway is a work in progress and a starting point. And we certainly invite your feedback and reflections on it, both today and offline. Next slide, please. So we welcome questions that you have. I think Carmen and Casey had mentioned the Q&A function in the Zoom app. We've included some questions here that we'll leave up for a minute that could maybe spark some questions in your mind. I think you can load those questions into the Q&A thing, and folks will moderate that and let us know what they are. And is there maybe a next slide with our contact info? I think the contact info is in the slide. Please feel free to reach out to me and Sam. We love to talk about this. And as I mentioned earlier, we're all engaged in this work. It's ongoing. We're trying to figure it out as much as everybody else. So we love to talk to folks, especially in the field, how this might be operationalized, how we might make progress. And our contact info is there. So I don't know if we want to go back to the question slide or if that's coming down. But I think it's time for Q&A. Yes, Carmen?
Yeah, thanks, Matt. Thanks, Sam.
Sure.
Really good job there. We've got about 40 minutes for discussion with the audience. And just in case you can't see the questions, the questions are really meant to stimulate your participation. They ask, what's the nature of your work? How did the Coal Run story resonate with you? Specifically, if you work in a public health department setting, how would you have responded if you'd received a call from that community? If you're a lawyer, what perspective would you lend as a legal practitioner? How do equity issues show up in your legal or public health practice, if at all? Does your leadership support health equity initiatives? And I read those not because I don't think you can't read for yourself, but because I know there are people that are coming in from their phone or perhaps don't have their eyes on the screen. We do want you to think a little bit about those questions and to please enter your comments and your questions. And we're getting a good bunch of questions, and I'm going to go ahead and start pitching those questions now. So the first question is from Daniel Mistak. Jails often don't have or share public health data, yet jails are locations where infectious disease spreads very quickly. Could either of you talk about the ways in which the criminal legal system create health disparities? And then if I might add, are there any examples you can think of where public health law has been able to impact the conditions in the jail systems with respect to public health of the people that are there?
I can hop in real quick. I mean, I certainly, the society-wide impact of the school to prison pipeline has been pretty well documented, devastating impacts. And so I think certainly the increasing incarceration of Americans has negative impacts for our society. And I think when you look at it from a public health perspective, in a public health point of view, public health approach, more policing and more imprisonment actually isn't making us any more particularly safe. I mean, if it did, right, we have more police and more prisons than any other industrialized country in the world. And we have one of the highest crime rates. So that approach is not working. And it's having devastating impacts on particularly communities of color, from the very basic political determinants of health, civic engagement, voting rights, to long-term health impacts that are clearly negative. So I think from public health, certainly we need data. It's something that there are groups at CDC who are working on this. There are actually a couple of pilot projects right now COVID has done a lot. COVID has uncovered a lot of things. There are some pilot projects at CDC working to establish disease and condition reporting systems from incarceration facilities to public health, focused on incarcerated individuals, folks experiencing incarceration. So it's a growing area. It's an area of interest. Public Health Law Program has worked with some of those programs and is engaging with them in conversation. So I have some hope that will expand. It's not very big. I'm saying it's pilot, but at least there's folks at the national level paying some attention to that. And there are prison, jail systems that are interested in pursuing that kind of system, and some folks making some investments into that. Sam, I don't know if you had thoughts as well.
I just had a brief thought, which is, the question asks about how jails have been used to expand or increase disparities. And there's a question about the sort of normalization of incarceration and the normalization of prison, which has become a pretty substantial feature of American life. And the public health implication, of course, is how do you have a society that can flourish if it is also normal to incarcerate substantial numbers of our population? And I think there's a space for public health to sort of make a public health case for the large, broad question about who we want to be as a society if we allow, and how can we have a healthy and flourishing society if we normalize imprisonment.
Great, thank you. So we have some really great questions coming up here. I want to get on to the next one. I work as a medical legal partnership attorney as part of a collaborative between Pediatric Medical Center and a legal aid organization. If you're familiar with the medical legal partnership movement, how do you see MLPs playing a role in promoting health equity and cooperation and integration between medical and legal service providers? Do you see this tying into the broader discussion of syndemics, intersectionality, and social determinants of health intervention?
We are really familiar with medical legal partnerships, and we haven't done sort of substantial sort of legal assessments of them, but we've worked in partnership with many who either run medical legal partnerships. Many of our interns work in them. And so there's a real potential there to kind of bridge that kind of data collection and analysis that we do at CDC to the practice component of the pathway that Matthew outlined. And from our perspective, medical legal partnerships have a place in that. Much of that work requires people to focus on sort of not just the legal question, but what's rich about them, what's important about them is that they situate the legal problems that many of their clients have in the context of their environments and the challenges that they're confronting. And that feels like that's like one of the key pieces of how you move the needle on talking about equity when you better understand what people's real experiences are.
Excellent. Matt, anything you wanted to add to that?
Yeah, just to echo what Sam was saying, I think too, I think there's an unexplored, maybe some places it's explored, but to me, there is a relationship to be explored between the way that medical legal partnerships experience the outcomes and the contexts at the individual level, and using the pathway or some other way to try to make change at the population level. We in public health, we talk a lot about and put a big emphasis on data, which we need. But I hope more and more that we put an emphasis on story, on community experience, on lived experience. And I think sometimes for contexts that's, we've talked about contexts that sit outside of traditional public health bounds. How do people experience housing? How do people experience poor zoning? How do people experience lack of access to healthy foods? That medical legal partnerships see that directly in specific individuals. And I think sometimes public health can lack that ground level knowledge and that kind of information. It may not be data, right? It may not be systematically collected data, but it is information about community experience and lived experience that could help set context for public health and inform directions and ways that they engage the communities. I think there probably needs to be more connections between MLPs and health departments. Would be something I'd do if I was the health director.
Yeah, those are great responses. And I want to just thank the audience also for actively reacting, for using your reaction buttons. I haven't seen them used a lot lately. And so it's really nice to know you know how to use them and that you're using them. It helps with the feedback, understanding.
Yeah, right on. I was just thinking that. I was like, oh man, that got a heart.
Yeah.
That's awesome. Okay, I'll keep going. Yeah.
So there are two questions that I think really relate to one another, and I'm going to include them. I'm going to sort of combine them a little bit. Has public health identified the housing crisis as a public health issue to help change harmful policies and ordinances at state and local levels? And then here's a story that connects to that. I live in unincorporated East Los Angeles, a segregated geographical area where people and other life forms have died and whose current and future generations will continue to suffer due to environmental racism. Currently, the state of California, through the Los Angeles Metro Plan, is imposing the building of 5,500 units within 235 parcels of land. This area does not have the infrastructure of health services to deal with this massive forced development. The LA Metro Plan will further gentrify this area that already lacks adequate health services. In the proposal, no CDC information was included. The proposal that exposes the cancer clusters and all of the chronic illnesses that plague our communities. Who can help assist us with filing a legal action in federal court to stop this pre-planned systemic racist state sanctioned discrimination, which we view as a violation of our human rights?
So on the housing question, that is probably one of the principal areas that public health, outside of sort of what we'd characterize as traditional public health, that public health has really begun to focus on. And I think there's I think it's fair for me to say that many in the discipline of public health view housing as public health, right? And characterize housing as public health. And without decent quality housing, it is very difficult to achieve good health. And with that in mind, a number of much of the work that we do at the Public Health Law Program involves partnering with health departments and with researchers and academic and other settings who are interested in understanding like legal issues and how they have an impact on health. And housing is probably one of the principal areas that many health departments that we've worked with have studied or thinking about housing and housing adjacent issues like zoning and public use, homelessness. So I think I think there's definitely a really strong awareness of the importance of housing for health. There's a housing and health work group at CDC. And, in the interest of not rambling about that, I think the point is, I think there's a fair point about that. On the environmental racism question in East Los Angeles, so we're not in a position to offer legal kind of guidance on this. I think it would be good to have a conversation maybe offline to talk a little bit about some of the issues implicated in this case. And we might be able to offer some guidance on where to go directly. But I do want to make an observation about the lack of CDC information in the city's metro plan. One of the things we're really trying to work on on a small scale, and we're hoping to expand that scale, is to work in partnership with organizations that are working in communities on these kinds of issues and that are doing analyses of policy and really trying to pinpoint the lack of public health data that can inform policy decision making. And it's actually one of the key features of the pathway when we talk about contextualizing data. The goal there is to better make connections between laws and policies and health outcomes, whether they exist or whether they're potential. But ultimately, the goal is to really better inform policy making, right? And that's a key feature of public health practice to begin with. And it's really important. We're recognizing the importance of making the connections between public health data and laws and policies in order to inform policy that's underway. One last point, I know I'm talking a lot, but one last quick point on this is one of the things we're also thinking about a lot is, there are lots of ways to make laws. We make laws in the legislature, we make laws at the policy level, at the state, local, and municipal policy levels. But laws are also made by the ways that judges interpret them. And we're trying to better understand how judges think about public health data and read public health data or engage with public health data, if at all. There's a real, we're recognizing the importance of how public health data can inform so much decision making in our society. So, Sophia, please feel free to reach out to me and Matthew to chat more offline if you'd like to.
I might also add that the California Planning Association, the planners, the city planners that you have in every city, and I don't know quite how that interacts with the metro plan, but the Planning Association has adopted a set of rules that actually look at a number of health issues with respect to how development is carried out. So this is a new element in the California General Plan, and that might be a resource to you as a document to help maybe gird some of your arguments or some of the approaches that you might be wanting to make it for your community's health. So I'd like to go on to the next question, and this just sounds like such a good one for both of you. How do you navigate all of the bureaucracy that comes with working within a government agency and all of the other agencies you need to work with in order to achieve change?
Carefully. I think the way that I approach it is doing a lot of self-learning. So, recognizing that we need to know about ourselves as we go down new paths, different paths, and pursue different things. And we need to increase our awareness of and our knowledge base of the areas that we're going to go into, whether it's structural racism, systemic racism, health equity, whatever it is. So I think first and foremost, as a thoughtful public health leader, we have to start within ourselves, understand who we are, where we have come from, what our context is, what is our lived experience, and how does that relate to the context into which we're going to go, and into which, assuming that at some point we're going to seek some kind of change, which is what we do in public health. We try to change things for the better. So starts with self. In the next stage is starting within, giving a thorough examination and potential scrub of what is the mission and the responsibility of the thing that you are part of. You are part of some sort of entity and organization. And once you understand yourself, I mean, this is the socio-ecological model, right? It's a self, and then where you are you situated, in what do you work, and what is that mission, and how can you leverage that mission and those authorities to bring about the change and move in the direction that you want to move into. And you have to have a very clear, fundamental, rock solid understanding of what that is. Because as you move outside of yourself and as you move outside of your organization, you are going to have to pitch and push and pull and leverage and convince and motivate other people to help, because none of us can do this alone. And if you don't have that fundamental understanding, it's very difficult to deliver the message of change that you're wanting to deliver and start to understand the different roles and responsibilities and formulate meaningful operational partnerships, right? Who am I? What is my skill set? What is the skill set and the mission of my organization? And then how can I help you do what it is that you're trying to do? We seem to have a similar connection, right? We're on the same vibe. We're going in the same direction. This is what I can do to help you achieve your mission. And together we can achieve so much more. I think once you sort of get to that point, you really have to sort of step to the side and say, okay, in what does my organization exist? For me, my organization exists within the Center for State, Tribal, Local, and Territorial Support, which sits within CDC, which sits within HHS, which sits within a presidential executive administration. I have to constantly be checking the health, awareness, well-being of that organizational structure. And if I understand myself, and I understand the core mission, motivators, drivers, and authorities of my organization, I can start to create the connections to the parts of my larger organization that are going to help me get done what I want to get done. And I maximize those connections and partnerships while trying to minimize and have allies in helping me deal with the barriers, whether they're financial, whether they're people in leadership chain that don't want to do what you want to do. And, you know, again, self, your immediate organization, clear understanding of that, and you start building friends and partnerships and allies. They can help you identify the places that are going to help you get done what you need to get done. And then also help you deal with the administrative, bureaucratic barriers and things that may get in your way. And I just emphasize, I cannot emphasize enough the, you know, that is a daily thing in leadership. You have to address that on a daily basis. The conversations may address different parts of that scheme or that framework, but you have to be assessing it constantly. And checking with immediate boss, checking with your leadership staff, checking with your staff, checking with your partners on all of these aspects, because these things change fast. People move into different positions. You know, what is the lifespan of a state health officer? It's like less than 2 years these days, I think. That stuff changes constantly. So you have to constantly be gathering intelligence, checking your gut, checking your assumptions, and keeping those connections to the bureaucratic systems that help you get done what you need to get done. And then also making sure you're fully aware of those parts of the system that will get in your way. And when you identify them, then figuring out, okay, what the heck are we going to do now? Boss doesn't want me to do that. So what am I going to do? Am I going to repackage this? Am I going to drop it? Am I going to put it on ice and come back to it later when he or she's gone? What are my options? It's not easy, but good work a lot of times isn't easy. So it's work. They call it work because it's work, but it's good work, right? I mean, no better place to put energies than this.
Very
That's how I
timely
think about it.
question for you here. How can the pathway for public health, law, and equity be applied towards developing strategies that address health harming laws impacting birthing people and access to reproductive justice?
Sam, I just monologued. You want to
Okay, I
take a
wasn't
shot
sure
at that
because
one?
you were unmuted, sure.
Oh, sorry.
That's okay. So I think there's a lot of opportunity there. We are actually, thinking about this, right? How folks in the field, folks in communities are sort of thinking about reproductive health matters. So, if we think about the elements of the pathway, it's pretty clear, right? We sort of we have to sort of define what the question is and what the challenges are. And in some ways that is a broad question that applies across jurisdictions, but it's also pretty specific to where people are because there's now even more variation in the law around reproductive access and reproductive health. And that, it's sort of like, well, what is the context in the place that we live in or that people live in? But also, what are the larger health implications of this smaller context? So for example, we think about things like maternal mortality, we think about things like early infant mortality, we think about things like, reproductive health and access to health services and so on. And we think about sort of issues that are adjacent to that, right? Like, reproductive health in the employment context and the decision-making that birthing people make around their reproductive lives. So there's that. There's the question of what is the context, both where we are and then more broadly. I don't think anybody needs to hear that law is a determinant of health on this question, right? It's a pretty powerful factor in this issue right now. And so then the question becomes, well, what is the law, right? Can we understand what the law is? What does it say? What does it do? What does it mean here in this city, in this municipality, in this state that we live in? There's one element of the pathway that's sort of, we highlight it and we talk about it, but we don't it's not one of the sort of bubbles in the pathway, that there's a kind of a community dimension to it, right? That what the law means and what the law says and what it does, there's some of the answers to that are determined by people living in a place who are affected by the law. And so as we ask this question for people working in public health settings or community settings, there's the look at what the health situation is and what the legal situation is where we are. But also there's the question of, well, what are people feeling in this place and how are they affected by the law? And what are they thinking about the law and what do they want? And what are some of the tensions around the law? Where's the conflict around it? And so being able to identify what those issues are and identify and talking to people and figuring out where people are and meeting them where they are with respect to these issues is a central feature of that process of like understanding the context and beginning to study the law. And then tying all of that And so from our perspective, what we do in public health law program, we might think about doing an analysis or an assessment of what the laws say and what they do, and how they sort of correspond with reproductive health outcomes within a particular state, or typically across many states. I know this seems very abstract, and if you want to talk about it in more detail, I would love to, and I'd be happy to. And then we do that analysis, and then we say, well, what does this all mean? What does the law do? How does the law impact people? What are the correlations we can draw between what the law says on the books in this state or in this city, and how birthing people exhibit specific health outcomes? What kinds of challenges do birthing people experience? What kind of challenges do they need to overcome? What are the needs that communities are identifying? And then I think there's that sort of like last piece of leveraging the law to imagine change. And I think there's a lot of ways to do that. Some of that is about figuring out what doesn't work with policy, or what does work actually, and what some of the sort of aspects of laws that make access to better health challenging, and ways that they might need to change. And there's another dimension, which is using that sort of expertise that's drawn not from studying laws around reproductive health, but also that recognition of what people in a place or in places have said they need, and figuring out a way to make a statement about how the law might change, and how public health can be really strategic about doing some gap filling where the law, doing gap filling based on what exists in the law. I'm being fairly cautious in the way that I respond to this question, because it's, there are so many question marks about where things are right now. But I think this is actually a really good example of how we might apply the pathway. And, again, I think beginning to have some conversations about that, and continuing some conversations about that would be helpful.
Matthew, is there anything you want to add? Okay.
No, I thought that was fantastic. No.
So what do you think is the most efficient way to influence laws so they are more equitable and influence policy proactively instead of reactively?
I think we have to rethink the way that we approach the issue of power. And we have to fundamentally restructure power in this country. And it needs, and that restructuring needs to come from a place of community and wellness and health, and working towards a horizon of politics. I mean, that's how it's going to get done. Public health is inherently political. We can't escape that. I think there was a period in public health where we did everything we could to avoid that reality. And I think part of why we are where we are is because we went through that phase, and we have lost much of the political power that we had, say, back in the polio days. And I think we as a field, as a profession, are suffering. And I think our communities are suffering because we've lost that power. We will either center our work on communities and the building of community coalitions and the building of community power, in translating that into making people's lives better, or we will cease to exist as an entity in this country. I don't think there's really two choices. I think there are only two choices there. There are forces that will take away what we have, take away our ability and our authority to do what we do. There have already been laws passed. There was a law passed in a state. There was a law introduced in a state this year to strip public health authority to conduct restaurant inspections. So I am not speaking hypothetically. I am speaking very, very concretely. And that is a law that was introduced into a political body that happens to be called a state legislature. There are many more around this country. And until we have the voice of communities behind us and driving the data and the science and the translation, the data and the science and the translation are not going to stem the tide of the rolling back of public health authority. It's simply not going to happen, because all of that feeds into a political system, which is okay. That's the way this country is, right? It's all political. Little p, political. It is the harnessing of the politic, the body politic, and using the voices of our communities to drive that change that they want, that they need, and to make improvements to their health. And until we do that, I don't think we're really going to make much of a difference and keep spinning our wheels like we've done for the past 50 years. And we have to fundamentally change how we do what we do. And we have to go down to the community and not constantly be looking up for Congress to rescue us or the state legislature to rescue us. That's not where it's going to come from, because that's not where we're going to get our power in order to make things better.
So I have a thought about that I think piggybacks off of Matthew's point, which is that part of the difficulty is that public health hasn't always done a great job of articulating for people why it's important, not just for keeping people healthy, but for keeping our society going and for keeping our society functioning. And so part of the story of needing to do business differently and do our work differently really means being able to make the case for public health, like why it's significant, why it's necessary, why it's imperative, and helping people to understand what we do. Like, what do we actually do and why are we here? And it's not just that we collect data, but we actually serve an essential function that helps us keep going. And I think being able to make the case for public health is not just important for like salvaging public health, but also for making a strong case for keeping our society going and keeping, for helping us to imagine what it means to have a healthy society where, again, I'm going to borrow your word, Carmen, where we can all flourish. So, you know, I do think that's part of the story of what it means to communicate in public health, and the sort of new focus on public health communication is great and really important, but I think we have to not just stop looking upward in terms of where power, figuring out where power really rests, but also like thinking a little bit differently about what communication means. How do we sort of meet people where they are?
So I'm going to ask one last question. I want to thank the audience for just asking such good questions. This is the final one. How are you working with and addressing the general pushback against public health in general in this political climate, and particularly in rural America, where there's a strong pushback against anything government run? I'm going to combine that with what are we doing in public health to create a voices pipeline? Fundamental change means we train community to be their voice and power. What does organization, who or what organization does that on a large scale, and who's focused on doing that? So if you'd like to comment on that, then we'll wrap up the discussion.
In like 3 minutes, 2 minutes, yeah. So I think, I mean, what we are doing, what Sam and I are doing is this. I mean, I think there's a, you know, I think of it as just speaking out, like speaking truth, and you know, I also think that we need to, you know, something that Sam said made me think of this, which is I think sometimes we need to speak to the community and the health outcomes and where we go in a positive sense. I think there's also a track that we need to explore and need to do a better job at, which is calling out the negative track. I you know, recently I might have been Katie Porter, the Congresswoman. It might have been somebody else. It was a congressional hearing after one of the mass shootings. And there was this whole segment about, you know, are you here for the mass murderers or are you here for the kids? Like really making these stark choices, because they're becoming stark. And I think public health is in a position, because of data and information expertise we have, is to call out those choices. Are you here for poisoning our groundwater? Or are you here for making that better, right? Like, what are you here for? Where's your interest lie? And if you lie about it, I'm going to dig up the information and call you out on it, because that information is available. I think that's part of it. That's not a complete answer at all. We don't have a lot of time, but I think that's part of it. And I think there's lots of folks looking at it as to who's doing it. I think there's lots of folks, and we could touch base offline.
Yeah. Sam, you want to add anything?
Yeah, I mean, I'm just thinking about the voices pipeline question, and I think this is like the thing we're trying to do. We are actually talking with health departments about these very issues. We work with future public health practitioners and public health lawyers, and we are talking about exactly this issue about voice and identifying where power and lies and how to build it. So,
yeah. Well, I'm sorry, Matthew.
Oh no, I was going to say too, and I think that's such a good point, Sam, because I think, you know, back to that idea of starting with self. You know, when I can't emphasize enough that when you are working with folks who are new to the public health workforce in the system, and even students, it starts with recognizing and listening to their voices. If you validate the input of new folks to public health, you are creating an environment where they understand that listening and encouraging voices is important, and that it's not direct, but then they're going to come into the system saying, oh, I got to listen to people, and everybody has a valid point, and everybody, you know, that we need to listen and open up the lines of communication. And that, I think that's such a critical part of what we have to do. It's not the only part, but it's an important part.
So I'm going to ask, I'm going to thank our speakers. You've just done such a good job of covering a very complicated topic in a very short period of time. here is a slide with their information for how to contact them. And just everybody should know, we are providing links to this recorded conversation in the Dialogue for Health website. And then as a last comment before we close, I want to put up the last slide, which just reminds everyone that the National Leadership Academy for the Public's Health, of which Sam Bentweber and Matthew Penn are key faculty, our applications are now open. So you can learn more about the Academy at this email address. It is sponsored by CDC, and we are really thrilled to hear that people are interested in it. And so please take a minute to look at it. Thank you, everybody, for this conversation. Thank you to the audience for just really deep, hard, difficult, and important questions. There's a lot of great work to be done, and we appreciate that you're all in this with us together.